when we met, I believe you were a senior policy civil servant in the UK government at that time. You've had many important positions, but I think it's fair to say that in all the time I've known you anyway, you have been really instrumental in setting the direction for radiation protection in medicine, both in the UK, of course, in Europe, and also internationally. So it's a great pleasure to have you here. Thank you.
Ola, thank you for that. And as a consequence, I'm going to say very little this afternoon. Basically, what I'd like to say, I think Ola's already said. And that's not a bad thing. Sometimes it's good to have things repeated or at least nuanced slightly differently. So this is a talk that builds on what Ola's said, but with nuance. Now, we all know what the basic safety standard might say and the ICR principles say about justification and optimization. And they fundamentally focus really on individual exposures if we take generic justification out. Last time I was in Egypt, like all good English people, I stole something from your culture. And you can see in this slide the two middle figures are obviously a referrer and a practitioner, a radiologist, who are discussing the benefits and detriments of a radiation exposure. And on the far side, there's a physicist who's making sure it's optimized. And this guy on the right-hand side, he's the regulator, making sure you're doing it all right. And in lots of countries, we're doing well. In some, we're not doing so well. The key thing, I think, when we're justifying and optimizing exposures is that we've always focused on individual exposures. And I've been a big believer in cumulative dose from multiple exposures should not affect appropriate justification of the next exposure. But what we need to do, I think, is think more carefully, as Ola's indicating, about what the clinical purpose of each individual exposure is. And I think I've listed some examples of what you might see a purpose of an exposure, a clinical purpose, during a pathway. And they differ tremendously. And some patients, as we've heard, go through multiple exposures for one course of therapy or one course in response to a clinical condition. Now, if we look at justification and optimization within the context of the exposure and within the range of exposures within the clinical pathway, we're not looking at an individual isolated exposure. We're starting to look at a whole group of exposures. And that makes sense. It makes sense if you're working in an environment where people are talking to each other, where we're in a multidisciplinary team and there's agreement between the various components of that team as to how to manage the patient over the fullness of time. So it's not really a problem if we've got the right people who are well educated and talking to each other, and therefore we can get a consensus on how to approach the patient. And one of the things that we see that helps this are protocols and guidelines. The question, I think, is that, as we've heard, guidelines, protocols, whatever you want to call them, they're fine for individual exposures and particularly for diagnostic ones. But when we get down to the line of treatment assessment and follow-up phases of a patient's experience, then the situation tends to tail off. And we're suddenly in an environment where we need flexibility on a case-by-case basis, because we need to consider where we are in the pathway and what the subsequent management and possibly what the treatment of that patient will be as a consequence of the imaging or informed by the imaging. So we've got referral guidelines, they're limited, that's okay, we need something else. Let's take a case study of someone with colon cancer demonstrated on colonoscopy. We've got referral guidelines for colon cancer, and we've got referral guidelines for secondary lesions, and these are taken from the RCR publications. And we've also got referral guidelines for secondary liver lesions, which sort of implies that the gold standard for for imaging liver lesions includes MRI. But do you need to do the MRI at every stage? Clearly, those individual referral guidelines that we have for diagnostic purposes are just not fit for purpose for all the stages and all the clinical purposes through the clinical pathway. And in fact, if we look at the UK recommendations from the RCR for cross-sectional imaging in cancer management, by the time we get to treatment assessment and follow-up, both for the colon and the liver, there's either nothing or something that's incredibly vague. So that means, essentially, if we're talking about protocols, until we have really patient-focused AI-supported protocols, we still need the radiologist, the referring clinicians to talk to each other and communicate about what happens next. So, for instance, if you've got a liver met and what you intend to do with it in the long term to treat it is to ablate it, the chances are, in most places in the world, you would ablate it under CT guidance. If you know the met's there and it's an isolated met, why do an MRI? It might be the gold standard for liver imaging, but what's the point? This is nothing about radiation dose, of course. This is about management of resource. So we need flexibility on a case-by-case basis with the right people making the right decisions. So in conclusion, we need to continue to justify individual exposures, and if we are looking at those individual exposures, they need to be justified on the merit of that exposure within the context of the clinical care that you wish to deliver. Protocols have limited capability to do this unless they're incredibly well developed, and I would suggest, and there are people here that are better qualified than me, that they're not there yet. I think when you're looking at a multidisciplinary approach, for instance, in the example of colon cancer that I discussed, the multidisciplinary approach now isn't multidisciplinary within the radiology departments, it's within the whole context of the treatment of that patient and the care of that patient. So who takes the lead? Who's going to take the lead if you've got a colon patient? Is it the colorectal surgeon? Is it the oncologist? Is it the liver surgeon? And who takes the lead at various stages might change, but we need to know who that is. So justification and optimization will differ depending on the clinical purpose within the clinical pathway. We need that flexibility, and we need to be clear that in some cases, if we have protocols and as protocols develop, the role of the radiologist particularly may change. It won't be predominantly someone who's justifying an examination, because the protocol will do that for us. The role of the radiologist might indeed to be unjustifying the examination, because the radiologist needs to talk to the surgeon to say, okay, what are we doing this for? Because if we're not doing the right thing for this patient's care, don't do it, use that resource for somebody else. So I think that's the nuance here. We're moving from people justifying examinations to unjustifying them if they're already established within a protocol. And maybe they're there, maybe they're not, but it's a word of caution for the future. So finally, there's no substitute for communication. And just like many things in Egyptian culture from the past, here we know things are being done correctly because people are talking to each other. And that's the important thing. If we're going to look at healthcare, which includes multiple exposures, we cannot act in isolation. We must talk to each other. Thank you very much.
Steve, thank you very much.